Starting. Sorry. Oh, it took me a second. Good.
Hi, I'm Julie.
Lee, how are you?
I'm great. How are you, Carrie?
I'm kind of missing you. You've been in
I
Colorado for a few days, so I haven't had much time to talk to you.
I know it's been lonely. We normally chat every single day.
I am feeling a wee bit neglected, I must admit.
That's okay. I'll be home soon.
Yay!
Yes, 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 yes. But it'll still be a while till I physically see you again, because you live on the other side of the state. It's a long drive.
We'll work it out. I'll
Yeah,
see you by the end of the month.
there you go. There you go. All right. So what are we talking about today in our unscripted sort of way?
Um, yeah, that's the fun of our page is that it's unscripted, so we never really know what's going to come up. So I thought today maybe we'd talk about some of our first and most exciting experiences that we remember, because we both have over 20 years of experience, and we've got some good fun stories.
I'm hoping that you mean as nurses.
Yeah.
Oh, okay, good. You were a little vague about our first experiences.
That first experience, I don't think we want to discuss that.
No, probably not.
No.
Okay. All
So,
right.
so I'll jump in if you don't mind.
Go
I,
ahead.
I remember, so I thought that I was going to have a job. I had done my nurse, or I'm sorry, like an internship, if you will, for my senior year in high school as a physical and occupational therapy aide.
Okay.
And the the person made me believe that I could continue to work there until I went to college. And I was like, oh yeah, that'll be fun. You push people upstairs, you do a little exercise. Well, when it came time to, then she's like, well, we really don't have room for you, but the CNAs could use you. Would you want to learn to be a CNA? I was like, I don't know, but okay. So I jumped in and I started taking the classes, and then they get to the point where you're going to start touching patients. And of course, this was all new to me, other than like helping grandma do a few exercises. So they put me in this room and shut the door. And that door felt so loud shutting it, because all of a sudden it was like you're in this room by yourself. And they're like, really simple. All you got to do is take your clothes off, wash the PTA areas, right? Pits, tits, and woo, and then put her in a clean gown. And I'm like, all right, I can do this. They did not tell me that this woman, and I believe her name was like Winifred or something. It was like a W name. But anyways, um, was so arthritic that she could not move, and she had some Alzheimer's. So all she could really do is yell and cry because she was in pain. So every time I moved her, it was like crack, 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 crack.
Wait, you were alone?
And I was all by myself. And I'm trying to change this lady's clothes and get her ready for bed. And I'm trying to be all sweet. And all I can hear is the cracking and her yelling, you son of a. And then that's all she could say was, you son of a B word.
Oh, that's horrible.
Yell. But yeah, it scared the bejeebies out of me. But yet I continued on. I persevered, and things did get better. But that first experience is one that I will never forget. That poor woman was so uncomfortable because she just had such arthritic joint pain. And I was like, oh my God, for the love of Pete, how am I supposed to get a shirt on and off this woman? How am I supposed to get her arms in here? And it was a challenge, but it was definitely one for the books to remember.
I think that, yeah. So my first patient was in the ICU. Well, I mean, my first patient obviously was when I was in nursing school, but my first patient as a nurse was in the ICU, and they were intubated, so they were on a ventilator, and it was the same thing. Give a bath, but luckily I had help, so my nursing preceptor was there, and we it's the same thing. You're washing them, and they're hold on just a second, and they're uh sorry, I lost track of my train of thought. And I remember conversing with him the whole time, but he's completely out. And my nursing instructor was like, "Oh, hey, that's great that you're having a conversation with them because you never know what they can hear, and you're using their name and being very calm and like, sir, I'm just going to wash you up here and I'm going to change your gown and we're going to do this and now I'm rolling you over." And I can remember that distinctly because in the beginning that's what I did, and I don't know if it was like that for you either when your patients were unconscious. Now you were in the ER, so that really doesn't count for you.
Oh, no, I did ICU for a while.
Okay, so in the beginning, it was very much like that. It's like it's not that I was always compassionate to my patients, but in the beginning, you're really respectful. You're talking to them, and then 6 months down the road, you're like joking with the people that you're with and talking about the night before you were doing this, and you're completely forgetting about the patient. And you're like rocking and rolling them. You're like, everybody up, turn, throw, wash, roll the linens, throw the gown on, scrub, scrub, scrub. And you're like, how fast can you get this bath done? Because you have other places to be.
Yeah.
Yeah. So that changes over time.
Yeah, unfortunately. Although I found that myself, even when somebody passed away, I would continue to talk to them as I was cleaning them up.
Oh, I did that too. Yes, I always but that's different because then you're not in a hurry generally. Because when I would bathe someone after they died, most of the time it was very chill. But I spent a lot of time with my people as they were dying. I usually we usually got to be more one-on-one with someone as they were passing away so that they had that companionship both for the family and the person, whether there was family there or not. I actually was with a lot of patients that died, and I think that was because I was good with families, but also good with talking to families about there was an option for the person to do withdrawal of care. I don't know if that was a thing for you either, but I was not about flogging people until their corpse gave up versus saying, let's have them have a respectful death.
Yeah, for sure. First time that I was with somebody that died, I was in nursing school and I was working in the intensive care unit in the neuro ICU at Froedtert. And this very unfortunate man had a brain bleed, an aneurysm that had ruptured. And at first, he was talkative and trying to reconnect with his family a little bit and whatever. And then he bled a second time. Well, the family and him were kind of not really on good terms. So when he bled the second time, we called the family and we said, we really feel like he's not going to make it. If you want to come say goodbye, this is the best time, blah, blah. And it was kind of a big snowstorm that day. And the woman's like, I just don't know that I can do this right now. And so I asked the nurse if I could sit with the patient, and because he had nobody there. And so it was actually kind of a neat experience for me personally. Like, I don't know if you want to say on a spiritual level, that I could sit there with him and hold his hand and talk to him until he passed away, and then help him after death to clean him up and get him ready to go. And then my nurse says, well, you've done all this and this has been your first time. How about if you walk him down to the morgue too? And I was like, oh no, that's where I set my limits. Because, this was all new to me. I was really young and I was naive, and, this is my first death experience, but I was not ready for quite that in depth of going to the morgue quite yet. But yeah, my first one, I felt like it was kind of a peaceful experience, but I also felt really good in my heart knowing that he would have died alone because his family couldn't get to them and didn't know if they wanted to get to him. But yet I could be there with him. So that was kind of a cool experience.
That is cool. Yeah, I think the most interesting death we ever had in the ICU was I had a Native American boy that was passing away. And so we had a lot of family. I mean, a lot of family. And they were singing and they were burning some incense. And it was quite the event that went on for a couple of hours because we withdrew care and he lived for a long time. But that was, we certainly, when we talk about providing care that's culturally appropriate, that took some organizing because normally you don't have, like burning things in the ICU.
No. I'm surprised when you said that they would even allow that.
Yeah, well, because it's more smoking than burning. We didn't have like open flames, But yeah, it was an interesting experience. You know, like I said, when you have a diverse culture
Yeah.
and I'm sure you've experienced that too, depending on where you've lived, you get definitely different experiences with death. And that was probably my most interesting, I would say, experience that way. Heartbreaking.
Yeah.
Yeah.
I think
I mean,
one funny memory that I have, again, from the neuro ICU, weirdly enough, was this gentleman had pissed off his girlfriend. Don't know how, don't remember that part of the story, but she took a baseball bat to his head and had to go to the surgery to get a big hematoma or a big bunch of blood removed from his head. And I asked if I could go in and watch because, you know, I was new to the department, and they let me, and I was all excited. I was like within an arm's reach of this guy's skull. I was that close to seeing his brain. And so it was really cool. And the doctors were explaining everything and all the good stuff. And he's like, well, since we didn't do an HIV test, I can't let you physically close his head. Otherwise, I would let you put the staples in. And I was like, oh my God, this is so exciting. You know, you see a guy's brain, you see this, all this stuff. It was so cool. Cool to me. So then a couple days later, the gentleman did herniate, and he unfortunately became brain dead. And so the family came in, and it's not funny that the patient passed away, but the funny part was that we walked in after we took him off the ventilator, and we still had to have the tube in because they're going to be a coroner's case because, you know, young death, whatever. So
well, he was murdered. There was the murder part.
Yeah. So you have to leave all the tubes and lines and whatnot in there so that they can see them. Well, we went back in there to check on him, and the brother was having one last beer with his brother. And he was pouring beer into the guy's ET tube, which maybe you know, maybe
into the lungs.
Goes to the lungs. So he was not necessarily sharing a beer with him in the correct way, but you know, it kind of gave us a little moment of, oh crap, what do we do? And then we're like, wait a minute. This is his final breaths anyways. He's probably not even breathing on his own. Let it go. But so it was an all around kind of an interesting scenario that we went from being able to see him go through surgery and then having his last beer with his brother. So
that's interesting. So that reminds me, neuro ICU was my was I spent a long time there too. But then in my early career too, we did a lot of neuro. And if you talk about like some of the most fun bedside procedures we did, it was always like both procedures where they drill in a pressure monitor through the head, or intracranial pressure monitors with drains where they again drill in a line through the head with a drain line out to let out the cerebrospinal fluid if the pressure in the head is too high. Right. And that was probably one of the procedures that I liked assisting on a lot. I don't particularly know why, because it wasn't the most exciting. There, I think I just liked
head stuff. Into his head.
So well, maybe that's what it was. Is they've got the hand drill and they're like crank, you know, or the little bzz drill, whatever it is that they're using. They're like drilling a hole through the skull after they get the little measuring tape, and they're like measure. I'm like, really? Is this the best way we can do? You know, here we go from here. And they're like, I hope you picked the right spot, man.
Okay.
And we always had residents, and when they were newer, you could tell they're like, I'm really hoping I'm measuring the right spot.
I think I can beat you on that one with that brain drain scenario. So I was a CNA or a tech, and you know, I knew that we had to put a brain drain in somebody. So that same drain you're talking about, and got all my equipment out, and I'm setting stuff up. And the two residents come in, and the one resident says to the other, I know I'm the one that's showing you how to do this, but it's been a little while since I did it. So could you go ahead and grab the directions so I can read them before we get started? And the patient is laying right there, which mind you, he probably couldn't hear anything, but we don't know that. And certainly saying this in front of the person that you're training and a CNA who's in nursing school, I was like devastated. I'm like,
admitting your faults. Look, or admitting your shortcomings. I'm all about saying what you don't know versus just winging it, especially when you're drilling a hole in somebody's head. Mm-hmm. That's the way to go.
But maybe you shouldn't say it in front of the patient.
He could have read the directions first, but the problem is the directions are sterile.
Oh.
If he opened the pack, I mean, he could have gone to the book. like the Big Book of Knowledge. He could have gone there.
A book?
Yeah, the Big Book of Knowledge.
No.
Okay, so what's your favorite thing, your favorite like monitoring thing to watch? Did you have one?
Oh, definitely when you have a Swan-Ganz.
I was just going to say the same thing. The Swan-Ganz, definitely my favorite.
Yeah. So can you explain to them what a Swan-Ganz is a little bit? 'Cause we have more
Sure.
ideas. Huh?
It's a catheter that goes up into the heart, and it can measure the pressures in both of all the chambers of the heart, the preload pressure, how hard the heart is beating, the pressure in the vein that's coming into the heart. It tells you all about the function. Normally, it goes into somebody whose heart is doing really, really poorly. A lot of the doctors that put it in, some of the doctors really don't have any idea how to monitor it, but that's okay. It's still pretty exciting. Putting it in bedside is always pretty cool because you have to just wait until you get, like, there's a flutter on the EKG that tells you went into the right area. But monitoring all of those numbers is like, you have to be like a mini computer and you're always looking at them every hour or every minute, and you're like, ooh, got a problem. And so normally when that's going on, as a nurse, you've got a whole crap load of drips. You see those pictures. You see those pictures like on in Facebook where there's a tower of IV drips going on, and you've got the one to keep the blood pressure up, and the one to make the heart pump harder, or the one to make it, the veins dilate or the arteries dilate, or and we're over there performing like complex decisions while the doctors aren't there because you don't ask them. You're just like screwing with stuff. I loved it. What about you?
Yeah. Mind you, I only really worked with swans and stuff my first year of nursing, because after that I switched to the ER.
And you wouldn't do them there?
Yeah, no, we didn't do that there. I did enjoy watching them put in chest tubes.
Oh, those are fun too.
Because if they do it right, you hear that pop and the whoosh of the air that comes out.
Or the blood.
Well, or blood.
Yeah.
Obviously those people are pretty uncomfortable. And then
I feel a little bit bad, but also good.
Yeah, because you get them feeling better and then they feel good.
Yeah. What's your favorite sick patient to take care of?
Oh.
I'm guessing. Sepsis?
Yeah, I mean, a good septic patient is always a good thing. I mean, not a good thing for the patient, but as an adrenaline junkie, you want those sick patients so that you can see them get better. And anytime you can get somebody who is got their blood pressure in the toilet, so really, really low, really fast heart rate, they're looking like yuck, they're barely responsive, and you can get them to the point of good blood pressure, good heart rate, got all the monitors on, get all the tubes and things going and the antibiotics going, and you know what the problem is, and you can nicely tuck them in bed and send them up to the ICU for them to untangle all the wires, then that's always a good day.
Yeah, because it's like, especially where I worked first, so many of our patients came in and they were chronically ill, and they would come into us with like heart failure or something to do with their diabetes, and they would be circling the drain, and I would pull them back a little bit and get them enough to go home, but they would still, they're what I always think about, those big orange funnels or those big yellow funnels where you drop a coin in and it spins around,
Yep.
They would be farther down the funnel, but I would have plucked them out of the hole, but they'd be farther down the funnel. And if this is like the death funnel, they're every time you send them home, they're a little bit farther down the death funnel. So you're not fixing them, you're just preventing the inevitable, and you're not sending them home in a good condition, but there's nothing you can do because they're chronically broken. And so I never felt good about that. I always just felt like, oh God, we saved Joe from death again, so he can go home and sit in his recliner because he can't walk around. His heart failure is too bad, and his legs are like tree trunks because he's retaining so much water.
Yeah.
Woo! Joe must feel great. But with a septic patient, you're like, I snatched him from the brink of death, and I have sent this 23-year-old woman home to have a great life, or whoever they are, however old they are. And you just feel good. You're like, I have done it good today.
It is a good feeling. It's a good
Yeah.
feeling, definitely, to be able to go from deathly ill to getting them laughing and talking and feeling much better. So that's always a
Yeah.
good feeling.
Yeah, it is. It
Um,
is. So on the good note, what did you ever screw up?
oh boy. Oh, that's a good question. Um, I don't know if I have a good one off the top of my head. Do you have a good one off the top of your head? Maybe I can think of one.
Okay, so when I was a travel nurse, so first of all, I have to preface this with travel nursing is like being okay, so it's like when you see those movies and they throw people into the pits with the wild
Yes.
the animals or the gladiators, not the gladiators, it's like the wild animals, and you have to somehow survive and live, right? So you better go in with a lot of good skills and an escape plan. So that's travel nursing, right? That's a good analogy, right?
Yep.
So you show up at this hospital in another state and they're like, okay, you know, our normal nurses get a couple months of training, and here's 1 day on how to use our computer system and a tour of the floor. And so here's the stock room and where to get your meds. Go forth and don't kill anyone. And right? And
Yep.
that's how it is. And then, so there was this one certain hospital I went to where we were supposed to get a week's training, and instead we got half a day on Meditech. Do you know Meditech?
Mm-mm.
Oh my God. It is the worst charting system known to man. I think it still exists, is DOS based. Have you ever used anything DOS based? Well, you're lucky. So everything is like function this, pop out. It's not Windows. So you can't use mice. You can't use a mouse, I mean. So you're just like popping in and out of all these menus. It is so bad that I have no words for how horrible it is. But so we had a full day on how to charge, or half a day on how to charge, and
Yep.
everyone was nearly in tears. I'm telling you, not joking. And I'm not the kind of person that cries. And then we went to the floor for our supposed orientation, and myself and another 2 other girls were there. And it was a very small ICU that wasn't even an ICU. It was a expansion unit that was all by itself in this little part of the hospital. We didn't have a stock room there. We had a stock room that you had to leave. I didn't even have a pulse ox on my ventilated patient because they didn't have one.
Oh
And
no.
they said, we don't have any staff to train you. Here's your patients. And I said, I am not okay with that. And they said, well, that's what we got. So here you go. So I called my nursing agency and they said, oh, that's not how that's going to be. Let me deal with something. And so they called the hospital, and the hospital said, well, tell her if she insists on needing training that we're going to fire her. And so I said, well, I guess I won't insist on training. Well, the problem was they used a lot of equipment I was never familiar with. I'd never seen it before. Okay. So here cometh the problem. So there's no one to ask because there's 2 nurses in the unit that have worked there before, and they're too busy to help us because we've got 3 ventilated patients. And as you know, that doesn't happen. You normally get 2 ventilated patients ever, and that's the max load you get. So I'm in there and I'm trying to survive. Everyone's trying to survive. This is survival. This is survival for us, trying not to kill a patient. And there's this tube with an alligator clip that goes into another tube. And I connected it together and I'm like, woohoo, that's how that goes, right? So later in the day, I disconnected it and walked away. And then I came in 5 minutes later and there's blood all over the floor. And that's how I found out that you don't disconnect it from the alligator tip. You pull the alligator tip off the line. And I thought this would have been one of those good things that they told you about. And this also seems like an extreme flaw in the manufacturing here. So,
Absolutely.
yeah, so I bled the patient.
Whoops.
Yeah,
Hopefully it wasn't too long.
nah, not that much really. It was
Couple
well,
quarters.
here's the thing about Florida. Did I mention it was in Florida? I didn't mean to mention it was in Florida, but now that we mentioned that it was in Florida, you just ought to know you have to flog your people to death there. We mentioned that already. You're not allowed to withdraw care in Florida. So this poor woman, even though she had a DNR order, we couldn't withdraw care
You can't
because
withdraw care.
no, you have to have two doctors declare that there is zero chance of recovery. And no doctor is going to say that. This came after the Terry Schiavo case.
Oh yeah.
Yeah. So after Terry Schiavo, a lady with like half a brain, the family argued about whether she could withdraw care. They changed the law there to say that you can't withdraw care unless two doctors say there's no chance of recovery, and no doctor's going to say there's no chance of recovery. But I had a poor woman who wanted to die, and she was already in a coma on a ventilator, and then she ended up with continuous dialysis, and then she ended up with, well, if you could have it and it was interventional to keep you alive, she was being kept alive on it. So she spent 2 months dying. That was heartbreaking. So we took turns going home in tears every night.
That's,
All of us.
That's hard.
Yeah, this wasn't funny. This is supposed to be funny. That wasn't funny. We took turns going home in tears every night.
So I don't know. It was cool to me at the time, and then now I think part of it was funny. I don't know, maybe it's not, but so I remember as a nursing student again, going in, and we all got to take turns seeing a surgery. And so this was my first one as a nursing student. The other one was my first one while I was working. Anyways, I was told that I would get to see a hysterectomy, and I was like, all right, sounds kind of boring, but all right. Well, what they didn't tell me ahead of time was that this woman actually had a mass in her uterus the size of a basketball.
Oh, wow.
And so I actually got to help hands-on hold the abdomen apart because she was a large woman. And then, they took this out. Well, it took quite a while to get her into surgery, and then it took quite a while in recovery. So I felt like I really bonded with this woman, right? Here I am, this student, and I'm all excited and gung-ho, and I'm like all lovey-dovey, and I'm going to hold your hand. I'm going to be your bestest friend. And she was super, super sweet. And I was so excited to see her all the way through. I took her up to her room, and I thought I'd never see her again. Well, fast forward a week later, this woman's stomach had dehisced because she's a very large woman. And sometimes when you have a very large person, and sometimes not, but they cough or they sneeze or something becomes infected, the wound actually will open. And so the wound had opened, and it was a cave. You could see right into her abdomen. And so we were having to do these big wet to dry dressings and all this stuff. And so the instructor asked me, do you want to take care of her again? And I was like, oh my God, we bonded so much. I totally want to take care of her. And I walked in there thinking this woman was going to be like, oh, Carrie, you're back. Thank God you're here to take care of me. I really enjoyed you, blah, blah. She did nothing but swear at me and told me what a dumbass I was the entire time. I was so heartbroken. I was heartbroken because here I thought this woman was going to be like all, excited that, this little nursing student was excited to come back and see her, and she got to be there in the surgery and all this good stuff. But I'm sure by then she was just done.
Over it.
She had been in the hospital. She had this big wound in her abdomen. And I don't know about her personality other than pre and post surgery and then that day. But yeah, it was heartbreaking because I thought this woman was just going to be like all gaga that I was there. And
yeah, it doesn't always work like that, does it?
No, it sure doesn't. But yeah. It was kind of funny at the time.
Yeah, the continuity of care doesn't always work out your way. We always tried to do continuity of care too, so patients would get the same person day after day after day. But when you work, I used to work 6 in a row so that I could be home with my kids more when I was a single mom. And by the time you're 3 days in on a patient that is very unpleasant, you're really despising continuity of care. Mm-hmm. That is the truth. Yeah.
Yeah. But as the patient, it is nice to know who will be coming in on the next shift and knowing their personality and that they know you and you don't have to re-explain yourself over and over. But yes, as the nurse, that's part of why I went to ER, because the longest I'd have to deal with them was that 8 to 12 hours, and then you'd get that turnover of a new patient. But
that's one of the reasons I liked ICU, because I enjoyed working with families a lot of the time. Sometimes they were pretty nuts and difficult. And I liked to only have a couple patients. I never liked working out on the floor where you got 5 or 6 or 7 patients, because I don't want my people to talk to me that much. I really liked it when half of them were intubated and only one of them really conversed. And especially in the neuro ICU, if you had two that were screaming at you or like off their rockers, that was just too much going on. I didn't need that much stimulation. That's for sure.
No.
Yeah.
Uh,
Who did you have a favorite doctor you ever worked with?
Yes, I would say my favorite doctor was one of the ER doctors, and he wasn't my favorite because of I don't know. He was an excellent doctor, but he also had an excellent bedside manner, and he treated you like a person. And that's why I respected him the most. Is that it wasn't like, oh, you're the nurse and I'm the doctor, so therefore you need to listen to me, and I definitely know better than you. He was somebody that would really listen to what you had to say and take your opinions into consideration. And then once a year, he would have a Christmas party at his house, and we would all hang out there. And his wife was super nice, and so that was kind of fun too. But I think he was probably my favorite just because of the fact that he actually took into consideration your years of experience, your knowledge, the fact that you're by the bedside, and actually could think for yourself and do things for yourself. On the flip side, we had a doctor, and he did not want to hear what you had to say, and he was probably the only man I've ever yelled at in a large public area, made his head turn red. And I went to my boss the next day and said, please don't fire me. I think I am in trouble. And she's like, what'd you do? I'm like, well, I may have yelled at Dr. So-and-so, and this is why. And she goes, all right, I'll expect him in my office.
Yeah.
I didn't get fired, but it was, I was just at that breaking point. We have such good information when we triage people, and we put them in a room, and sometimes they tell us things that they don't tell the doctor, but this doctor wanted nothing to do with my information. I was like, I had it. I'm like, anyways.
We had a doctor at my very first hospital, and we'll call him Dr. So-and-so. And he, when I first started, very first day, they told me that when he rounded, we needed to be standing outside our pod ready for him when he showed up. Now, mind you, this wasn't for anybody else. We didn't do that. We needed to be standing there ready for him to give him information. And I'm brand new, but I'm older than all the other nursing students because I was in my 30s. And I said, why would we do that? And they said, well, because he expects that. And I said, well, I'm working and it's the end of my shift. I expect to finish my job. And so I never did it. And when he showed, and he was from a different country than we are, and he didn't respect women. So never in the whole time I was there did he call any of us by name. He just called us nurse. But he would show up, and then he would call and he'd say, nurse, nurse, whatever. And he really did not appreciate that I wouldn't come out for him. But I would say, I would talk to him, then I would say, whatever, you need, I'll be there in a second. I'll give you the information. If you didn't have something written down, he didn't want to hear it from you. He wanted it to be written down on your chart. And I'd say, I didn't have time to chart that yet. My patients are dying, whatever's going on. But I had an incident like you did one day. I was working the night shift, and I had a patient with the flu who also we put a swan in overnight because he was very sick. Yeah. And at shift change, he was coding. So he was going into cardiac arrest. And we were doing, and so this doctor was the pulmonologist. So he managed the ventilator. And we were doing CPR. And he came in and he started screaming, literally screaming at me about why did we put in a swan overnight? What were we thinking? Why would we do that? We made him sicker, blah, blah, blah.
Like the nurse have any choice in the matter. We don't put the swan in.
Well, it doesn't matter because the intensivist wasn't there at the time. And so I'm doing the CPR and we're trying to record the code, and I lost it like you did. And I started screaming and I said, Dr. So-and-so, I do not have time for this right now. I need you to, I think I said, shut up or get out because I'm trying to save his life and this is not the time. I don't remember what else I said, but it apparently was rude and I was very concerned. And the same thing. But no, I did not get in trouble. He left, and he was never rude to me again, ever. He didn't call me by name for sure, but he definitely stayed out of my way the rest of the time that I worked there. But yeah, he was completely out of line. But yeah, I mean, like you said, when the doctors respect your opinion, or at least are willing to listen to it, it makes them so much easier to work with, because I'm not right all the time.
No.
But to at least listen when you've been there. And with working with residents, a lot of them are better than they used to be, because they've learned that they don't know. They came from school, but they've never worked with people before, with humans, right? Because they've just come straight out of medical school and into residency, and they don't know. So that listening is a big piece, and that collaboration. Collaboration goes a long way.
Yep.
And the doctors see people for 5 minutes a day, 10 minutes a day, and you're there with them for 12 hours. Well, 6 hours for one patient. However you want to look at it, we're friggin' there all the time seeing them. So if I see a change and I call the doctor, or I want to do something and I call the doctor, I very much expect that they're at least going to listen to what I have to say.
Right. Agreed. Yeah. I mean, and I work with nursing students now too, and then obviously I've worked with a lot of residents. And part of the problem is they don't know what they don't know, right? Because they haven't experienced it, and they haven't been there. And so we can offer that knowledge and that background of, I've been doing this for how long? This is what I'm seeing. This is why I'm concerned. And then when they don't want to hear it, or they don't want to believe you, it gets very, very frustrating. So it is hard to hold your tongue when it comes to young professionals that are just starting in their careers.
Yeah, I one day my charge nurse told me that I needed to stop. What did she say? I needed to stop telling them to shut the F up. And I said, I'm not saying anything. And she said, well, your face is saying it all the time.
We do both have that resting bitch face. You have to
yes. No, she said it's the what the hell is wrong with you face. Like the are you an idiot? And I said, I'm going to have to get in the mirror and work on that.
Yeah.
Because I said it's their problem, not mine. If they're doing it, apparently I'm saying it, and I can't help that. My mouth is not speaking.
I know. But, I do not have a good poker face either. You can tell right away if I'm pissed off or angry or frustrated, and I don't know what to do about it, but I try.
Mirror exercises, apparently. I don't know what those would be. Well, neither of us actually practice with humans anymore, so now I guess it's easier because we can't. But I still run into people. I don't know about you, but you go to the hospital with somebody that you're related to, or you go to the hospital yourself as a patient, and I know my face is going, what the hell is wrong with you? Yeah. And it doesn't work well. So I try to keep a peaceful, quiet look on. I try to look like I'm a moron when I'm listening to people now. Mm-hmm. Like just keep a vapid smile look on your face.
Yeah, but like I said one other time, the biggest problem for me is I've been going with a lot of medical appointments with now 3 parents, my mother-in-law and my mom and dad, and they can't shut up. The first thing they have to say to everybody is, this is my daughter. She's a doctor of nursing. She worked in ER, blah, 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 blah. And so they treat you different and they look at you different. And then it makes it even harder for me because they know I have medical knowledge not to say stuff like, hey, you're being stupid. Don't do that.
Right.
Excuse me, doctor, you're being stupid. You can't do that. But,
right.
And it is what it is. But
yeah,
life's interesting. It definitely changes over the years, and my life's changing a ton, just going from bedside nursing, which I miss, to working with nursing students. And I really work now with nursing students who are just starting to get into the practice of touching patients and doing things. And sometimes I really have to back myself off and be like, all right, Carrie, they're not professionals. Give them time. Let them think about it. Because I work in an area where we use simulators. Yes, you got to meet one of them. And so I work with a pediatric mannequin or simulator, if you will. And So I bring students in and I'll create these scenarios, and then they have to walk through the scenario and try to make the patient better, stabilize them or whatever. And it's kind of a fun way to do it, because then they really have that hands-on piece and they have to think about things and they got to work through it. But certainly it does take them a little bit of time to get used to it. I have one last, can I tell you one little funny story about the simulators? And then, so I used to do pretty much nothing but the simulators. That was my job. I was the sim coordinator. And so I did a ton of just sitting there doing these simulations. Like, I don't even know, probably 25, 30 hours in my week, I was sitting there doing these simulations. And that's a lot. Like, I had other things to do in my job, but I didn't have time for it. Well, anyways, and I would do these junior adult health ones over and over and over again. So you kind of got bored and you'd try to find ways to entertain yourself. And so we decided that before people would go in, that we were going to set up the room with some things going on there, that they had to walk in the room when it was dark as if the patient was sleeping. And I said, okay, you can learn things even when you walk in the room if your patient is sleeping without ever touching them. So I want you guys to take 2 minutes, walk through their dark room and see, what can you identify? Maybe there's something, the blood pressure's wrong. Maybe their heart rate's wrong. Maybe you can hear them breathing funny. Your other senses can kick in and you can find these things. Well, we had these, and I didn't know that this group of people were walking in, but we had these brand new mannequins, and the mannequin made this really cool noise. And so I said to my sim tech, watch this, I'm going to scare them. And I made the mannequin scream, and they were in the dark. And so they weren't expecting the mannequin to talk, and it screamed. So they all screamed. So I'm laughing my butt off. Well, at the same time, there's a tour of high school kids walking in the door. So all these poor students are in there trying to be like all calm and like looking around for things. And then I make the mannequin scream really, really loud. And I just couldn't stop crying. I was literally, tears were streaming down my face. I'm like, oh, time to go. And I snuck through the other door and went in there, and it was pretty funny.
That is funny.
It did scream pretty loud, and it was pretty obnoxious. And that's how you entertain yourself when you're a simulation instructor. You make your noise. My pediatric one will actually turn its head and look at you. So if you're talking, he'll turn to look at you.
I don't like that.
Yeah. And then when I was there yesterday, we have some new mannequins that are coming in that we were looking at. And she was telling us about another one that they have that we probably aren't going to buy because it's a lot of money. But it actually has AI technology now, so it can talk back to you without a microphone. It's just the mannequin itself makes the conversation. You can say, I understand you're having abdominal pain. And then the thing will say, yes, my tummy hurts a lot right here, or whatever. But it can also have a stroke where like the side of its face will look like it's stroking. You go to say, can you grasp both my hands? And it grasps them both. And then the one side becomes weaker. Like, it's almost too realistic for me. I think I would start to get a little freaked out, but
that's pretty cool.
It's cool though. I'm kind of curious what it's like. But anyways, all right. Well, should we wrap up for today?
Yeah, I think so. That's pretty good.
So you are in Colorado today, which is actually a really high elevation. And so one thing that I always do when I go to high elevations is I always make sure that I have a really good sunscreen on, because I like to prevent skin cancer because of the fact that skin cancer runs in my family.
Yep, and I have it with me.
And I just got mine in the mail, but maybe you could talk a little bit about our sunscreen.
Sure. I love it. It's a stick sunscreen and it's all mineral. But unlike other mineral sunscreens, have you touched it yet?
I haven't. I'm just opening it now. I'm kind of excited.
Ooh, you're going to have to put it on. So it glides on absolutely silky smooth. It does not have that zinc, grimy, can't rub it in feeling. So it just does, it goes on light and creamy, and it'll go under over your makeup, and it doesn't leave any sort of layer at all. Don't put that much on, lady. It takes only a tiny bit to rub it in. Yeah, see, that's a bit much there. One little stripe on each cheek and a little bit across your forehead, and you put too much on. That's why you're turning white.
Well, I'm red from a hot flash, so it's okay.
There you go. But it'll It is an SPF 50, I believe, and it is, because it's mineral based, it is reef safe. The really, really awesome thing about it is that it not only prevents skin damage in the future, but it can help reverse skin damage from the past. So it will help remove some of those brown spots that you might have, or age spots, dark discoloration. And so it is definitely my favorite sunscreen I've ever had in my life. And I've been using reef safe sunscreen for a long time now because I like to swim in the ocean and scuba dive. And this one is just phenomenal. I carry it in my purse so that I can put it on during the daytime over my makeup, because you should be reapplying your sunscreen every couple of hours to prevent skin cancer. And I'm a big proponent of skin cancer prevention, because nobody should be wanting any skin cancer.
There's no excuse for it anymore. Yeah, no, my father-in-law had it. My mother-in-law just had some removed. My dad gets multiple treatments a year for it, and definitely something. And my brother-in-law, I actually sent him to the doctor. I'm like, that mole on your head, you need to go in. He's like, oh no, it's been there for a little while. It's fine. I'm like, go get it looked at. And
what do you think about how it feels?
It's lovely.
Doesn't it feel nice? It's really silky and light, and it just rubs right in, and then it disappears. You don't feel it after a second. It's just gone.
Yeah, it's beautiful.
Yeah.
All right. Well, I am super excited to see you in a couple weeks in live person. We will put our little music back on for a few seconds, and then we will see you guys soon. Have a great day.
All right. See you next week, guys.
Good night.